it's such a pleasure, actually, because, I mean, what you'll hear us do is basically agree. I think MRD is clearly a very exciting new tool for the future. What I simply want to share with you is some of the cautions around its use, and perhaps frame it in the context of how we're encountering its use in our clinic in counseling patients, perhaps, and guiding them about what they're doing with their therapy, because I think critically important in this debate is understanding the implications in different settings. MRD negativity in newly diagnosed patients, I think, has a very different place than it does, for example, in a relapsed refractory patient. And the data that I really want to emphasize there before I get into my nitty-gritty of the technology is around, for example, the value of minimal response. In our relapsed refractory setting, we have patients with minimal response over many years to pomalidomide therapy from the original trials, and they're doing just fine in terms of their quality of life and disease control. And I think one has to set that context as clinicians to what we're talking about and recognize where this tool may be best suited and best serve our patients going forward. So my remit from Bob was to sort of give you a different texture to what you heard so nicely from Ola, recognizing that Ola is a world leader in this disease. And basically, I look to guidance from my colleague Nikhil Munshi to guide me on this one particularly, but hopefully I can just give you some flavor of some of perhaps the cautions. This is a definition of MRD that is any approach aimed at detecting and possibly quantifying residual tumor cells beyond the sensitivity level of routine imaging and laboratory techniques. And my point really here is we have to be a bit careful in this field right now, because there is a lack of standardization in definition, which I want to share with you, and varies between diseases and technology used. I think we're aware of that as practicing hematologists, but really to sort of frame that in the context of this morning's discussion. Now, you heard beautifully from Ola why MRD is important, and I would wholly agree. I think the important point is, however, that whether or not this is something you should be using in your offices, or whether it should remain at specialist centers, at least for now, until we quite know what we're doing. There's that lovely old term, and I use it primarily for myself, that, you know, a fool with a new tool is still a fool. Until I know how to use this optimally in each setting, I need to be careful how I deploy it. MRD, obviously, having said that, is very important, and the sensitive molecular techniques that can identify patients with residual disease at the molecular level are vital, and obviously not only in the research setting, but actually also, I'd argue, in the regulatory setting, as we look to test new drugs and find methods to get drugs approved as quickly as we can, providing they're obviously efficacious for our patients. This obviously is clearly a very suitable and appropriate technology. I wanted to frame it a little bit more broadly around other hematologic malignancies. Obviously, in leukemia, this has been around for a while, but I want to emphasize the message of this slide, which is that basically secondary endpoint has been the uniform sort of unifying parameter here for both ALL, AML, APL, CLL, and indeed CML as well. Now in CML there was a primary endpoint analysis, but very interestingly, some of you may be familiar with the very recent work just presented, which shows that with 10-year follow-up in a very large cohort of CML patients treated with TKIs, MRD negativity actually did not translate into clinical benefit parameters in a way that was expected. So that was fascinating, and just perhaps a cautionary tale. So how does this then move into the Bcell malignancies? Well, obviously it's a secondary endpoint in follicular lymphoma, secondary endpoint in mantle cell, and in multiple myeloma. The comment really from, and this is actually courtesy of some pathology colleagues of mine providing their perspective, considerations of MRD are less advanced than in leukemia and lymphoma. I think that's fair to say. And all I would argue is that that then gives us some cause for caution going forward. Now, in myeloma, you heard just moments ago from Ola, so I don't want to reframe it, but I would just actually agree and say absolutely treatment advances have increased the likelihood of achieving CR, and this is a representative slide of that effect. The critical point is, though, that we have an array of technologies to deploy, and that's all I really wanted to bring to this particular slide, was to show you the diversity of strategies that have been studied, and to also bring to your attention the differences between flow and PCR, next-generation sequencing. This is obviously the method that is summarized here, just to give you an idea that it exists. It's very important. It has a limit of detection that is obviously supposed to be superior to flow, although Spanish colleagues would argue that their technology has now evolved in a way that Spanish flow is as good as next-generation sequencing. I think that's an area of very active debate. I think Ola and Nikhil and others who I consider leaders in the field view it as probably not the case, that next-generation sequencing is the way to go. And I'll just give you some ideas around that. This is just data to support that, showing the differences. And again, they're summarized in this slide as well. Again, not to belabor the point, but just to emphasize that the technology is an evolution, summarized there. Okay, you can also, oops, I'm sorry, go back one slide if I may. Maybe I can't actually on this machine. Here we are. That in fact, obviously you can look in blood and bone marrow, and there's actually a good correlation. So that's an interesting aspect to bear in mind. Now, MRD status is clearly predictive of outcome, both pre and post AST. That's data that's very strong. We've seen that in a series of trials. So again, in the context of trials, in the context of outcomes with time to progression and other clinical benefit parameters, MRD negativity matters. Now, in terms of the overall view, I do want to share with you some data from my colleague Nikhil Munshi, who's done a very nice meta-analysis that's actually in press right now in JAMA Oncology, because I do think it supports the argument that MRD going forward has real potential. So I'm going to sort of emphasize this because I think it's relevant to showing you that MRD in the future, I think, will become something hopefully that's prime time, but perhaps just not yet. This is a really nice piece of work from Nikhil and his colleagues, and basically what they've done is to look at a large number of trials. As part of this meta-analysis, they've looked at specific MRD papers. They've got PFS studies in 13 and overall survival studies in 9, basically allowing them to look at a very large number of patients. And basically, this is just the methodology behind it. So in the interest of time, I won't dwell on it. But suffice to say, MRD negativity does translate into a meaningful clinical parameter compared to MRD positivity, and these results are very highly significant. What I think is interesting as practicing clinicians, though, is just to remember that MRD negativity doesn't mean you've won the war. You really haven't. It just gives you a clue that you might do slightly better than if you're MRD positive. So I think we need to be very careful about one other approach, which is that MRD negativity means you could stop treatment. That's not what this data is telling you, and I think that's very important to share. I'm personally not a fan of reductionism in treatment. I think this disease warrants a continuum of therapy, and I think this kind of data emphasizes that point because, as you can see, if you're MRD negative, you're doing better, but you're still relapsing and still dying. This is indeed a CR-achieving patients from Nikhil's meta-analysis, and it emphasizes my point. You're MRD negative, you're still relapsing. You're MRD positive, you do less well. So it's not a zero-sum game again, if that doesn't sound too repetitive. You must keep a baseline of therapy, even if you're MRD negative, in my view. What about the effect on overall survival? That's summarized in Nikhil's paper here. So the conclusions of the meta-analysis are here, that MRD is predictive, but most of the results that I just showed you were based on flow, and we've already said that flow has its problems. The emerging role of next-generation sequencing remains to be defined. So is it time to use MRD to direct therapy? Arguably as a research tool and perhaps as a regulatory endpoint, perhaps not, though, as standard of care. And why? Well, there are a few things to bear in mind. If you look at flow methods, I want to spend just a little bit more time on this. We've got patchy disease, aspirate hemodilution, staining methods, also a number of colors, antigens studied, number of events. This is specific to flow. And if you look at limits of detection across 91 labs across the United States, very grateful to my colleagues in the Alliance for providing me with these slides, actually, from our path call. And basically what you can see is there's a great deal of variance, that's the point, across the 91 labs that test MRD for myeloma. So, look at those graphs. They tell you something. There's a lot of variability. So while some labs report an LAD lower than 0.001%, some report them as high as 1.0%. So again, beware of that in practice. So the summary from my path colleagues at the Alliance is there's major heterogeneity in how the labs surveyed define MRD. Flow remains the dominant methodology, but obviously next-generation sequencing presumably will supervene, but we will need to wait and see. And based on this, there's going to be an enormous amount of standardization and improvement needed. You already saw this slide earlier. I just want to emphasize it as a practical point. You can see MRD negative patients do well, but only better than their MRD positives. I do want to bring your attention to this. Basically, with long-term follow-up, your MRD negative patients, 50% of them are progressing. So what does that mean? To me, it means you don't stop treatment. That's number one. And perhaps what this means is that if you're MRD positive, you do more. If you're MRD negative, you have a limit of treatment, perhaps, but we've got to be careful about that, at least a baseline of treatment, a baseline of therapy that you use. But I think this, to me, was very sobering from the New England Journal paper. 50% of these patients who are MRD positive pursuant to the study, regardless of arm, are relapsing within 4 years. And this also translates into survival impact as well. So take home, MRD and myeloma routinely being used in the setting of clinical trials, yes. Flow cytometry has been a mainstay, but we would argue molecular strategies are probably the way to go, and I'm very glad Ola agrees with me because it's tricky. And the use has been for prognosis. Therapy adjustment has really not yet been done on MRD, so we need to be careful. And I would propose to you, being very much a clinician in the clinic versus a pathologist, that the lack of standardization is a problem. And these are some of the points from my Alliance Core colleagues. So I would argue it is not yet a standard of care that you should use in the office, but obviously, hopefully, it may be. Thank you very much.